So what are the methods that are used in pathology to help understand the disease process? One is the gross examination. So when we talk about pathology, we have to break it down into two components. There is the anatomic pathologist, who I am, for example, and I don't do the CSI cases, the forensic cases where it's suicide, homicide, or accidents. That's not what they ask on the USMLE. Most people will have diseases that are natural processes, like having a cold, getting a swine flu virus, getting AIDS, or skin cancer. So when we talk about the gross, we're looking at the anatomic alteration of the disease process versus the other component of pathology is the clinical pathologist, who's looking at electrolytes, the blood chemistry, CSF findings in terms of the chemistry that makes it up, the CBC. These are things that one sees in the clinical realm of pathology, or the microbiologists and immunopathologists looking at leukemias and lymphomas. So when we talk about the gross examination, we're looking at two major components. One is obviously identifying what the organ is. That's related obviously to the anatomy. So if they show you a photograph, the clinical vignette will often tell you what the specimen is, or they may want you to think about what the organ is based on its location. Then obviously identifying what has altered the tissue, so you always have to go in with the idea you have to know the normal anatomy or the histology, and then what is different about this. And that becomes an important part of looking at pathology and relating it back to the disease process. So what are the usual gross features that we look at? There are basically four of these, 2 S's and 2 C's, the way you think of it. The first is the size. They'll obviously give you dimensions in metric system, not the English system, and it becomes important. Is it 1 centimeter versus 20 centimeters? So if you have to convert it back to inches, remember it's 2.5 centimeters per inch. Another important thing is its shape. There are a lot of adjectives that are used in medicine, and pathology is no exception. It becomes critical because the description is more important than the label you give to it. That's just a label. Everybody wants to get to the label, but in order to understand the disease process, you have to have all these other components to define it. Because I always tell students that if you had one book on an island somewhere studying for the USMLE and you ordered it from Amazon.com, many people would say first aid, they would say the syllabus notes, Harrison's, pathologic basis of the disease that a lot of you have used in the past. It would be none of these. The one book that covers all these disciplines, and that's the essence of this exam, is the medical dictionary. That's why it's called MD, medical dictionary, not doctor of medicine, because it's definitions. You should always look up the words. When you think you know what the word is and you can't define it, it's time to look at the medical dictionary. Because I tell students the best way to understand the disease process is to understand the lexicon or the nomenclature, because once you understand why that term is used, it gives you a connection to that information that will now serve you. So when you see that disease process or a description of it, that definition is its defining moment, and that's what you have to look at. So when we talk about the shape, think of stellate. Is it round? Is it irregular? All of these well circumscribed. These are indications of the disease process. Now you have to translate it. What is it defining? So the dictionary. So if you're studying for the USMLE and you come across a term you don't know and pretend you're a patient right next to you and the patient asks you, doctor, what does this mean? And if you spend more than 20 minutes trying to describe it, that means you're a politician and not a physician. You will not pass the USMLE. You need to go back and define it within 30 seconds. It'll make life easy for you on the exam as well. Another important thing is that you can't do on an electronic exam is touch the tissue or the patient, so they'll describe it to you. Is it soft? Is it firm? Indurated? Is it hard? All of these are descriptive terms. It's again reflecting to all the things we talked about in terms of the disease process. And then the other important thing that's critical in pathology is the color of the organ that's been altered in the disease process. So for example, if we look at the myocardium of a heart, why is it brown? Because you have to understand why it's normally what the color of each organ. We'll go through these different organs and think about what the color and what it represents biochemically, and then when you have a disease process superimposed on it, what is that going to do to that organ that a pathologist uses to say, you know what, we have a problem with this organ because it's changed its color. as well as its consistency. So what do I mean by this? So when we talk about the myocardium, why is it red-brown? Biochemically. Let's go back to biochemistry and think of what the heart has to contain to carry out its physiologic function. And that is, it contains the metal iron. And the iron is found as in cytochrome C oxidase. It's critical to this organ because it's found in the mitochondria. Remember, oxidative phosphorylation, it requires a lot of continuous ATP production. And therefore, if you now damage the heart, and the most common cause of damage in the heart in the United States is ischemic heart disease. Therefore, we have a myocardial infarction, the heart muscle dies. So as the cells break down, and including the organelles like the mitochondria, what's going to happen to the colored tissue? It becomes pale in color. So that's again a reflection of what's happening biochemically. The color alteration becomes critical to recognize, yep, this is a dead heart, this is not viable, and that's what they want to come across that defines the disease process. So color is critical to you in medicine as well as on this exam, and anybody who sees these tissues or organs with their naked eye becomes critical in describing the color. Radiologists, they're not have that capability. They can add color to it on a computer, but it's not the same thing. That's why radiologists need pathologists. And we need radiologists too. Microscopic examination of the tissue. This is very important as well because obviously there are things that can look very similar at the gross level that have to be now correlated microscopically so that it's allowed to basically make the connection. And that's what they like to do on the USMLE. They'll say that there's a biopsy that's taken. And when they describe the gross organ and now the microscopic to help distinguish it from other possibilities. So we use light microscopy. On this exam, they don't show a lot of images. They'll describe it in the stem, whether there's an autopsy or a biopsy, or they'll give you in the choices a description. Then you have that description defines what disease that led to those morphologic changes. So the gold standard in the world of pathology as well as histology is the hematoxin eosin stain, and this becomes critical. It's just not memorizing this stain that we just mentioned, is what does it bind to? What are these molecules that are pigments that are critical that's going to, in a normal tissue, and then when you have an abnormal process that alters the tissue, what does the pathologist uses to make the diagnosis or defines that disease process? And so when we talk about hematoxin, it basically binds to nucleic acids and calcium salts. Because as you recall, calcium is about 1% is ionized and can be bound to negatively charged molecules, and becomes a blue or purple appearance. Eosin, and the critical thing you should remember, it binds to the vast majority of proteins, and your favorite color in pathology, histologically as well as histology, is the color of pink. Because when you see pink or it's described, and there's various terms, we'll get to this, that describes that as proteinaceous material, and this becomes critical. There are other histochemical stains or chemical reactions that are used that help define various processes that the hematoxin eosin stain, or H&E, is not able to do, and that is, for example, iron. We'll come back to this later on when we talk about diseases where you have too much iron, like hemosiderosis versus hemochromatosis. And what's the difference between the two becomes critical. Osis means what? Condition of. There are a lot of oses in this world. And so when you talk about hemosiderosis, it's an increased total body iron stores without tissue damage, while hemochromatosis is where you increase total body iron stores leading to tissue injury, leading to damage. And that's very important. So you can see by knowing the definitions, and if these terms come across or the definition of these terms come across in the exam, it becomes critical to your understanding. So Prussian blue, obviously it's going to be a blue color when it binds to iron. Congo red, obviously we think of amyloid. And what's the definition of amyloidosis? It's a condition of abnormal deposition of extracellular protein leading to organ dysfunction. And this is important to realize. And Congo red is pathognomonic, which means what? It means it only stains to those that have beta-pleated sheets, and we'll talk about that later on when we get to amyloidosis. Another important stain you see in microbiology as well as pathology, you can actually add acid-fast stain to tissue to look for organisms like tuberculosis, MAI, and other type of organisms that will bind to it. Proteotic acid shift, or PAS, is the vernacular that's used by the pathologist. And what is it like to bind to is carbohydrate moieties within the tissue, and becomes very important when you look at carbohydrate content on the surface or the walls of fungi, for example. We use it for fungal content, or it can in the tissue if you try to look for fungus. And then the other thing is you look for carbohydrate and extracellular matrix proteins, where, like, for example, you'll see increased carbohydrate content and alteration when you talk about diabetes mellitus and glomerular lesions. Gram stain, obviously you use in microbiology. You can also do it on tissue, gram-positive, gram-negative organisms. And then trichrome stain is used to look at extracellular molecules. Like, for example, when you have the trichrome stain on connective tissue, it'll give collagen a blue color, while smooth muscle cells will be a red color. And so it helps the pathologist to ascertain the consequence of disease process in terms of the amount of collagen deposition, or what we call fibrosis or scarring. And this becomes critical when we look at various diseases that will produce scarring in various parts of the body. And then reticulin stain is basically a stain that binds to an extracellular structural molecule that's very critical to your understanding. We'll talk about this later when we get to tissue repair, and that's collagen type 3. So when you're learning histology and you hear the reticulin fiber, what they're really talking about is collagen type 3, and it'll give you a black appearance in terms of the extracellular deposition. Now, this is a table that's found in your syllabus. Now, this is an example. What do we do with lists? And when we have lists like this, we don't look at it as just a list to sit there and memorize. Let's take, for example, hematoxin. We talked about it is blue to purple. And obviously, nuclei, nucleoli, bacteria, calcium salts, and so forth. What happens to a list, you know what you've tried to do for your exams during medical school, is that what happens to a list in 5 minutes versus a half hour? You forget it. So why do you do it? Is there a better way? Absolutely. So now go back and think about what you did in the 3rd grade and how that'll help you study for the USMLE. If you think in the 3rd grade in math, what did they ask you to do at that time is that when you had fractions and you add 1/3 to 1/2, what do they always ask you to find? The common denominator. And that common denominator is critical. So when you look at this list of blue to purple, what is the common denominator? Nucleic acids and calcium salts. So if they describe something blue or purple on H&E, you know what it's going to have to be made of, and think of the context of the disease process story that fits into this. Let's look at eosin. Look at all these things: cytoplasma, collagen, fibrin, red blood cells, thyroid colloid. What are the common denominator? Protein. So what color is it going to be? Pink. And that's the critical thing you need to realize, is that you never memorize a list. You know what's going to happen. It's a waste of time. And you want to understand the common denominator, and this applies across all disciplines, no matter what you're studying: biochemistry, pharmacology, physiology. Because guess what, on the USMLE, what are they going to ask you is not about memorizing lists. They're going to ask the question about the common denominator. And if you understand that, you're going to do quite well. And you'll say, I wish I could take this exam again. So again, the common denominator is the critical part. You want to look at any lists, and this slide of this table is in your syllabus notes. Now let's look at the microscopic examination, and let's look at the light microscopy. When we look at the light microscopy, again, they're not going to emphasize you memorizing and go out and buy these books on high yield images. It's a waste of money and time. They really want you to define the disease process, and this is just to augment it. It's a reflection of the disease. So on light microscopy, there are other things besides H&E that one can use that we cannot see. So let's think of things that we can highlight. So you think of these as color reagents, and one important stain is called IPOX, or immunoperoxidase, or immunohistochemical stains. Essentially what you're doing is taking an antibody, labeling it with a molecule that will either give you a color reaction when it binds to a specific epitope inside the cell, outside the cell, on the cell surface. And what are some examples that you've learned about? All those CD markers: CD4, CD8, CD19, CD20, CD68 for macrophages, and all these. All this is a reflection is making antibodies, or estrogen receptor that you need in breast cancer, for example, or progesterone receptor, which is intranuclear. So the staining will help you understand what molecule is being produced, expressed in that cell, and is it too much, is it not enough, or how can we use it as a way for prognosis. For example, in breast cancer, you want to know if drugs like tamoxifen you're going to use, and they usually do it whether it's estrogen receptor positive or negative. So we can make antibodies to intermediate filaments. We'll talk about this when we get to the neoplasia section. So cytokeratin is the intermediate filament between the tubulins, which are the larger cytoskeletal proteins you recall from cell biology as well as histology, versus the tonal filaments. That's why they call it intermediate. So in all epithelial cells in the body is the intermediate filament called cytokeratin. This becomes very important. What's an example of this you learned about is Mallory bodies. You think of that you see in acute alcoholic hepatitis, where you get this clump of pink red material in the cytosol. It's just clumping of the intermediate filament called cytokeratin. And it becomes important when we talk about most cancers that are malignant are epithelial origin. So this becomes important for the pathologist. Vimentin is an intermediate filament that's found in non-muscle mesenchymal cells. So what do I mean by non-mesenchymal cells? We're talking about fat cells, adipocytes, fibroblasts, talk about osteoblasts, osteoclasts. And are there stains for the muscle? Yes, and we call this desmin. And desmin, what are the three muscle cells that we recall? Smooth muscle cells. We have cardiac and skeletal. And so that becomes important identifying, like for example, a leiomyoma of the uterus. We know it arises from the myometrium, but if you had to prove that it's smooth muscle origin, this is the stain that one could identify that it's of smooth muscle origin. Prostate-specific antigen, we'll talk about serum tumor markers and how they're important in medicine. Remember, these are never used to make a diagnosis of a disease process because there are non-neoplastic conditions that will elevate it. And remember, tumor cells do not read textbooks. They can either make it or not. And we'll get to that when we get to the neoplasia lecture to address this. And there are many others as well. Other ancillary techniques that are used, you can use immunofluorescence. Now, this becomes important to you on this exam, and that is the following, is that we use immunofluorescence in renal diseases. And this becomes important knowing what the pattern, is it linear or granular? When they talk about granular pattern, we really talk about immunocomplex, clumps of molecules, versus a linear pattern where you have an antibody bound to a specific epitope in that tissue, in this case along the base membrane. What's the classic disease you'll learn about that's a linear pattern is Goodpasture's or anti-glomerular basement membrane disease. The other thing you should remember about the USMLE is that the terms that they use, the labels for disease, they can use any one of these. So you have to be able to understand there are all synonyms that can be used on the exam. You don't know which one they're going to use, but you don't care, you're ready for it. Another place you use immunofluorescence is autoimmune diseases. And the classic one they love to ask on the USMLE, we'll get to that when we get to the immunopath, is systemic lupus erythematosus, where you have both immunocomplex deposition in various parts of the body, but also antibodies bound to a cellular structure like platelets, red blood cells, and we'll get to those later on. Another important technique that's used, again, is transmission electron microscopy. And again, it's to renal diseases. They'll tend to describe this to you on the USMLE, or they will give you a rare image of an electron micrograph, trying to see if you can find where the deposits are located. Are they subepithelial, subendothelial, or are they just going to the mesangium like an IgA nephropathy or Bejer's disease? Another important place that used to be is transmission electron microscopy, use neoplasms. You won't see any questions too much on the USMLE because what has supplanted this is the immunofluorescence and other molecular techniques we'll talk about. Infections, obviously you can see, you think of rabies, intracellular organisms. Like rabies, it's a bullet-shaped virus versus the AIDS virus, which is circular. So the shapes of these viruses you learn in microbiology become critical when you relate it to the disease process. And then genetic disorders. And we think the classic example where you can't metabolize material, like in lysosomal storage diseases, where you have these complex molecules, as you recall, like Tay-Sachs or Niemann-Pick, where now the cell can't break it down in the lysosome, which now the autophagy that's taken place within the cell can't break it down and it accumulates, and the cells just get bigger. And we'll talk about this when we get to genetic disorders and what it leads to, the signs and symptoms and the outcomes of these disease processes where you cannot metabolize it. So in the case of Niemann-Pick, because you can't metabolize sphingomyelin, it accumulates and we get what are called zebra bodies, these alterations. Since it's a complex lipid, long fatty chain lipid that has negative and positive charges, it'll try to form bilayers in the cell. Other techniques that are used are molecular, and this is things like protein electrophoresis. What do we think of? Thalassemias, alpha or beta, where you can see on a peripheral blood smear the target cells, as you recall, basophilic stippling, where you have clumping of the RNA in the cytosol, but you can't tell the difference between if it's alpha or beta unless you do electrophoresis. Because remember, what does thalassemia mean? And this is important, get out that medical dictionary, because thalassemia, what do they call it, means thalo means C, decrease C, because these were described in patients from the Mediterranean Sea, so you remember that story. It's easy to recall. Another important thing is you look at a southern and western blots. You can look at antibodies to various proteins. These are things that are used like western blots initially in the diagnosis of AIDS or the suspicion the patient has been exposed to the AIDS virus. Obviously, an important thing that's occurred because you have to amplify the signal whether you have a disease process like a virus like AIDS, where you can look at the viral load by using polymerase chain reaction. And so amplifying a very small change becomes critical in understanding the disease process. And that's where modern pathology is now heading toward, is the molecular pathology, which is another branch of the anatomic pathology. And then another important thing they do like to ask about on the USMLE that's critical is cytogenetic analysis. And what do I mean by that? Those diseases that involve whole chromosomes like Down, when you talk about karyotyping, or you can now isolate various genes by using what is called fluorescence in situ hybridization or an in situ hybridization technique. So you can actually, under fluorescence, identify where on the chromosome the gene is, or it hasn't been processed appropriately, or you have recombination events, so this becomes very important. And that is the end of the first chapter, the fundamentals of pathology, and we'll go on to the next, which will be cell injury.